Welcome to today's NCLEX RN review session. So this time we're focusing on key cardiac diagnostics and management, which are essential knowledge for recognizing and responding to cardiovascular conditions on the NCLEX RN. So today we will be covering interpreting cardiac tests, including echocardiogram, ECG, transesophageal echocardiogram, or known as TEE, Lexiscan stress test, and Holter monitoring, and including cardiac monitoring essentials, identifying those ischemia, arrhythmias, and heart failure progression. And so we'll also recognize and manage infective endocarditis, including priority interventions and patient educations. We'll also include critical assessments and warning signs to detect early deterioration and prevent complications. And our goal is to enhance your critical thinking and clinical judgment so you'll feel confident answering NCLEX RN questions on cardiac diagnostics and management of life-threatening dysrhythmias. And it would also be great if you complete the entire Q&A and comment below your scores and let us know about what you've learned. So let's get started. Question number 1. A 55-year-old male client presents with severe chest and back pain in the emergency room. His vital signs are unstable with a blood pressure of 80/50 mmHg. Bedside transesophageal echocardiography confirms a dissecting aortic aneurysm with a pericardial infusion. Emergency surgery is scheduled. And before transferring the client to the operating room, what is the nurse's immediate priority? Options. A. Administer Levophed at 4 micrograms per minute to increase blood pressure. B. Insert 2 large bore IVs to collect lab samples and begin fluid administration. C. Prepare the client for immediate pericardiocentesis. D. Give labetalol to reduce afterload and contractility. The answer here is letter B. And why is that? Well, just before we're going to delve into the section, the dissecting aneurysm or the dissecting aortic aneurysm is a life-threatening emergency that requires immediate surgical intervention. And the patient is already hemodynamically unstable with a blood pressure of 80/50. And so the priority is stabilization before surgery. That's why the correct answer is letter B. So we need to have the large bore IVs access to ensure to facilitate the administration of IV fluids and also possibility of administration of the blood products, which are very critical in maintaining the perfusion and also to prevent further cardiovascular collapse. Now, what about letter A? Why is this incorrect? It said administer Levophed at 4 micrograms per minute. Well, this is incorrect because the patient is likely to have hypovolemic shock due to the blood loss from the dissection. And when you give vasopressors without volume resuscitation, this can worsen organ perfusion and further constrain the already compromised aorta. Letter C is also incorrect. We know that pericardiocentesis is sometimes necessary to relieve tamponade, but it is not the priority in this case because the patient's condition is unstable and the surgery is already planned. So when the surgery is delayed because of pericardiocentesis, this could be dangerous and the pericardial effusion should be managed surgically during the emergency operation. Now, letter D is also incorrect. We know that labetalol is a beta blocker, but this is contraindicated in this case because it can cause further hypotension. Take note that our patient's blood pressure is 80/50. It can also decrease the contractility and can decrease the afterload. And so in a client with an unstable blood pressure, the administration of the labetalol would likely worsen the hypotension and it can negatively affect the patient's ability to maintain circulation to the vital organs. So in this task question, I want you to pay attention to the word clues. We have inserting large bore IVs, which actually supports circulation and preparation for surgery, while we have Levophed right here in letter A, although it can increase the blood pressure, but again, if you're not resuscitating fluids first, this can worsen the hypovolemia. Now, letter C, talking about pericardiocentesis, this actually delays the surgery, which is the definitive treatment. Now, we have letter D, labetalol. This is something that can reduce the afterload and also decreases the contractility of the heart muscle. And this can further drop the blood pressure, and this can worsen the shock. So I want you to prioritize the interventions that stabilize the patient before surgery, and also use the ABC approach: airway, breathing, circulation, and the circulation is the greatest concern in this case. Let's have number 2. A healthcare provider has prescribed a transesophageal echocardiogram, or TEE, for a client suspected of having endocarditis. What should the nurse prioritize as the initial action based on standard TEE preparation protocols? Options: A. Administer lorazepam Ativan 1 mg intravenously. B. Establish an intravenous access. C. Implement NPO restrictions for the client. And D. Initiate oxygen therapy via nasal cannula. Your answer here should be letter C. And why is that? Now, I want you to recall about the transesophageal echocardiogram, which is a specialized procedure that is used to obtain detailed images of the heart. And this is particularly useful for diagnosing the conditions like endocarditis. So this is quite different to the echocardiogram because the TEE involves the insertion of a probe into the esophagus, which provides clear image of the heart structures. Now, because this procedure requires sedation and this can suppress the gag reflex, your top priority is to ensure NPO to prevent aspiration. Now, why is NPO the priority here? Well, during the sedation, normally the body's natural reflexes like coughing or swallowing are greatly diminished. And so if a patient has recently eaten, there's a significant aspiration, and this can lead to pneumonia and respiratory distress. Now, this is a non-negotiable prerequisite, and so without it, the procedure cannot safely proceed. Now, what about letter A? Is administer lorazepam 1 mg IV. Well, this is a sedative that is used often during TEE to reduce anxiety and also to help the client tolerate the procedure. However, giving it isn't the first step. It's basically administered closer to the procedure time after NPO status is confirmed and IV access is already confirmed and it's patent, right? And if you're administering this too early, this could unnecessarily sedate the patient before preparations are complete. Now, letter B, establish an IV access. Well, we know that this is important for sedation administration and emergency interventions, but it comes after ensuring NPO status. Now, if the patient isn't yet NPO, inserting an IV prematurely doesn't contribute to immediate safety. Now, what about letter D, initiating oxygen therapy via nasal cannula? Well, we know that oxygen is sometimes used during the procedure, particularly for sedated patients, but it's not a standard procedure or pre-procedure requirement unless the client already has respiratory issues. And since there's no mention of hypoxia, starting oxygen is unnecessary at this time. And so the key here is timing and safety to your client. And so enforcing NPO status is your first priority because it's a prerequisite that must be met well in advance, typically starting 6 hours before the TEE. And the other options, IV access, sedation, oxygen, are also important but can occur later, often just before or during the procedure itself. Let's have number 3. A client presents with intermittent chest pain and has a medical history that includes severe peripheral vascular disease, smoking, diabetes, and hypertension. His troponin levels are abnormal and his ECG levels reveals a left bundle branch block. The cardiologist has ordered tests to assess for myocardial ischemia. Which diagnostic test would be most useful in identifying myocardial ischemia for this client? Options: A. Regadenoson Lexiscan stress test. B. Magnetic resonance imaging. C. Exercise treadmill stress test. D. SPECT perfusion imaging with technetium 99M system B. The answer here is letter D. Now, so here's the thing. When you're evaluating myocardial ischemia, especially in a patient with left bundle branch block and severe peripheral vascular disease, picking the right diagnostic test is very critical. Now, I want you to remember that the left bundle branch block can mess with the ECG readings, and it will make it hard to spot those ischemic changes, and the peripheral vascular disease can limit the exercise tolerance, so not all tests are practical. And that's why the best choice here is SPECT perfusion imaging, because it directly assesses blood flow to the heart and it is not affected by the left bundle branch block ECG abnormalities. Now, the key clue to the option D is that it can detect any perfusion defects. It can also detect ischemia, and this is reliable despite the left bundle branch block. Now, what is SPECT? Well, this is the single photon emission computed tomography that works by injecting a radioactive tracer that highlights the blood flow to the heart muscle. And if certain areas receive less blood during the stress, but if it improves at rest, that is a clear sign of ischemia. And so, unlike the ECG-based test, the SPECT can directly visualize the perfusion, and so it will make it much more reliable for those patients with the LBBB, where ECG findings can be misleading. Now, another reason why SPECT is ideal, because the patient in our case has severe peripheral vascular disease, so simply means that a treadmill stress isn't an option. And since the SPECT can be paired with pharmacologic stress agents instead of exercise, this remains a safe and also an effective choice. Now, what about letter A? Regadenoson or Lexiscan stress test. Well, this substance, regadenoson, is a vasodilator stress agent that is used in nuclear stress testing, but the left bundle branch block can make ECG changes hard to interpret. And this can lead to false positive or inconclusive results, so it will make it less reliable unless paired with imaging. We know that the regadenoson is sometimes used alongside SPECT, but SPECT alone remains the best choice in this case. Now, what about letter B, magnetic resonance imaging? Well, we know that this is very fantastic for spotting those structural heart problems like cardiomyopathies or congenital defects, but it is not the go-to test for myocardial ischemia. Even though the magnetic resonance angiography or MRA can visualize blood flow, it's not as effective as SPECT for detecting ischemia-related perfusion defects. Now, what about letter C? This is another incorrect option. We normally know that treadmill stress test would be a solid choice, but recall that our patient has peripheral vascular disease, so walking or running on a treadmill may not be possible. Plus, the left bundle branch block can interfere with the ECG-based ischemia detection. And so this will make this test unreliable in this case. Now, for you to answer this question correctly, and I want you to consider both the test's accuracy and the patient's physical limitations. And so we know that the LBBB makes ECG-based tests very tricky. So an imaging-based approach is better. And also consider about the peripheral vascular disease that the client has, which actually can limit the exercise tolerance. So this rules out treadmill stress testing. And the test should directly assess blood flow to the heart, so making this SPECT perfusion imaging the more effective option. Number 4, an adult male client is hospitalized with suspected acute pericarditis. Which diagnostic test should the nurse explain as the most relevant for evaluating this condition? Options: A, continuous cardiac monitoring with a 24-hour Holter device. B, blood culture analysis. C, echocardiographic assessment. D, cardiac catherization. Answer here is letter C. And why is that? Well, when a patient comes in with a suspected acute pericarditis, choosing the correct diagnostic test is critical. And the main concern with pericarditis is whether pericardial effusion is present. And if too much fluid builds up around the heart, it can lead to the cardiac tamponade, which is a life-threatening emergency. And so the best test should be one that directly visualizes the pericardium and detects fluid accumulation or inflammation. Now, why is letter C the correct option? Well, echocardiography is the gold standard for evaluating pericardial conditions because it directly visualizes the pericardium and any excess fluid. And even if pericarditis doesn't always cause fluid buildup, an echocardiogram can help out in ruling out dangerous complications like tamponade. And this is also non-invasive, and it's widely available, reliable, and it's going to be the go-to test for this type of evaluation. Now, why is letter A incorrect? Well, for sure, Holter monitor can record the heart's electrical activity over 24 or even 72 hours, which is great for spotting arrhythmias, but it does not assess the pericardium. Even though pericarditis can cause EKG changes, continuous monitoring won't confirm the diagnosis or show any pericardial effusion. That's why letter B or letter A is incorrect. Now, what about blood culture analysis? This is also incorrect. These are only useful if there is bacterial pericarditis is suspected, which is not the most common cause. And most cases of acute pericarditis are viral or idiopathic. Simply means blood cultures won't provide useful information unless the patient has fever, maybe sepsis, or hemodynamic instability. And so instead, C-reactive protein, the erythrocyte sedimentation rate, and cardiac enzymes are better for assessing the inflammation for the pericarditis. Letter D is also incorrect. This is not the first-line test for pericarditis. And this invasive procedure is primarily used to evaluate coronary artery disease, valvular disorders, and intracardiac pressures. And even if it can detect hemodynamic effects of pericardial effusion or tamponade, echocardiography is still preferred, less invasive diagnostic method. And the catheterization is only considered in complex or unclear cases where constrictive pericarditis or hemodynamic compromise is suspected. Now, for you to answer this question, you have to recall that pericarditis is an inflammatory condition that can lead to fluid accumulation. And the best test should directly assess the pericardium and also to detect effusion. And it's also non-invasive, which is also preferred unless an invasive procedure is absolutely necessary. Now, what about number 5 here? A client with acute heart failure who is intubated has been admitted to the ICU for treatment. Which of the following clinical signs is the most reliable indicator of adequate cardiac output for this patient? Options: A, serum creatinine level of 1.0 milligram per dl and an alert mental state. B, ejection fraction greater than 50% on echocardiogram. C, no presence of peripheral edema. D, respiratory rate of 22 cycles per minute with an oxygen saturation of 94%. The answer here is letter A. Well, the point here is that when you're assessing cardiac output in a critically ill patient, the key is to check if the heart is supplying enough blood to the vital organs. And the best indicator is how well the brain and the kidneys are being perfused, since they need a large share of the body's blood flow to work properly. And why is letter A the correct option? Well, I want you to recall that the kidneys receive about 25% of the cardiac output. So a normal creatinine level of 1.0 suggests that the kidneys are being adequately perfused. It simply means that there is sufficient cardiac output. And similar to that, the brain is also highly dependent on oxygen and nutrients delivered by cardiac output. And so an alert mental state suggests that the brain is receiving adequate blood flow. And I want to emphasize that when there is cardiac output drop, if there is a significant decrease, there's going to be an alteration in the mental status, there's going to be confusion, there's going to be lethargy, and there's going to be worsening of the kidney function, such as an increasing creatinine level as early warning signs. Now, what about letter B, ejection fraction greater than 50% on echocardiogram? This is an incorrect option, even though a normal ejection fraction greater than 50% may indicate normal heart function, but it doesn't always correlate with adequate cardiac output. And there is that heart failure with preserved ejection fraction, or known as the HFpEF or HFpEF, which is a classic example. And the ejection fraction with this type of heart failure can be normal, yet the cardiac output is still inadequate due to poor ventricular filling or diastolic dysfunction. And so perfusion status matters more than the ejection fraction alone when you are assessing the cardiac output. That's why letter B is incorrect. Now, what about letter C? No presence of peripheral edema. Also something that you should discard, because the presence or absence of edema is not a direct measure of perfusion. And a patient can have adequate cardiac output and still have edema due to fluid retention from other causes, or they may have poor cardiac output without visible edema. Letter D is also incorrect, although oxygenation and respiratory rate are critical vital signs, but these do not directly reflect cardiac output. And so when even a patient may have normal oxygen levels, but they can still suffer from poor organ perfusion due to an inadequate cardiac output. And in addition to that, mechanical ventilation can also sustain oxygenation, can potentially obscure the signs of impaired perfusion. And so when you're choosing the best indicator of cardiac output, I want you to think about end organ perfusion. So think about what organs require a steady blood supply. So I want you to look for the direct signs that the brain and kidneys are functioning properly. So look for mental status and kidney functions. Now, you have to be cautious of options that describe general cardiac function, such as the ejection fraction or fluid balance, such as absence or presence, or no presence of edema, without directly assessing the perfusion. Now, since cardiac output is all about delivering oxygenated blood to the vital organs, a normal creatinine level in this case, and a alert mental state strongly suggests that the client has adequate cardiac output. Let's have number 6. A client with infective endocarditis and an elevated temperature has been admitted. Which healthcare provider order should the nurse prioritize implementing first? Options: A. Obtain blood culture samples from 2 different sites. B. Administer ceftriaxone 1 gram intravenously. C. Schedule a transesophageal echocardiogram. D. Provide acetaminophen as needed for fever relief. The answer is letter A. Now, when you are caring for a client with infective endocarditis, your first priority is to identify the causative organism. And that is why obtaining the blood cultures from 2 different sites takes priority, because it can provide a critical information to guide the antibiotic therapy. And so if antibiotics are given before drawing cultures, the results may be skewed, and this can make it harder to target the infection effectively. Now, the rule of thumb in infections: always get cultures before starting antibiotics to ensure accurate treatment. Now, what about letter B? Why is this incorrect? Now, we know that antibiotics like ceftriaxone are the mainstay of treatment for infective endocarditis, but giving them before obtaining blood cultures can compromise the ability to pinpoint the responsible bacteria. And since identifying the specific organism is critical for choosing the most effective antibiotic, administering ceftriaxone too soon can actually be a misstep in this case. Now, what about letter C? Schedule a transesophageal echocardiogram. Well, this is an important diagnostic test for endocarditis, right? Especially for detecting valvular vegetations and also to assess cardiac complications. Although this is valuable, it's not the immediate priority. So unlike blood cultures, delaying the TEE by a few hours or even a day would not significantly alter the treatment outcomes in this case. Now, what about letter D? Provide acetaminophen as needed for fever relief. We know that acetaminophen can make the patient more comfortable, but it does not address the root cause of the infection. And fever in this case is a clinical sign of IE, and suppressing it without first obtaining the blood cultures could make it harder to monitor the infection's progression. Now, your test taking strategy to answer this question is to think culture first, then followed by antibiotics. And also think about the diagnostic tests that directly affect treatment decisions, like blood cultures in this case. So this should be prioritized before carrying out those interventions like medication administration of antibiotic or, let's say, imaging. 7. A nurse is caring for an elderly client with heart failure. She recently underwent an echocardiogram, and the cardiologist explained that she has classic diastolic dysfunction. She feels uncomfortable asking the doctor to clarify what this means. How should the nurse explain diastolic dysfunction to her? Options: A. The ejection fraction is 35% and the left ventricle takes less time to empty. B. The ejection fraction is 60% and the heart's left ventricle takes longer to empty. C. The ejection fraction is 55% and the heart fills more slowly during the early phase. D. The ejection fraction is 50% and the heart fills more slowly during the late phase. The answer here is letter B. And why letter B? Well, because when a client has a diastolic dysfunction, the heart still pumps effectively. It simply means the ejection fraction is preserved, but it struggles to fill properly during the diastolic phase, which is the relaxation phase of the heart cycle. Now, the problem is not with the pumping out of blood, but with the heart's ability to relax and receive blood effectively. Now, this can cause the left ventricle to take longer to fill because it becomes stiffer and less compliant. And in the diastolic dysfunction, the ejection fraction remains normal, typically between 50% and 75%. So we focus on how the heart fills. Now, why is B the correct answer? Well, it actually acknowledges the normal ejection fraction of 60% and also explains that the heart's left ventricle takes longer to fill. And so this is the key understanding the problem in diastolic dysfunction, which means the ventricle doesn't relax well and it can cause a delay in the filling process. Now, why is letter A incorrect? Well, it's because it talks about an ejection fraction of 35%, which indicates systolic dysfunction when the heart cannot pump blood effectively. Now, systolic dysfunction would be characterized by a decreased ejection fraction. So this doesn't match the diastolic dysfunction scenario. Now, what about letter C? 55% ejection fraction and the heart fills more slowly during the early phase. Well, this might seem plausible because it suggests the heart fills slowly during the early phase, but it's still not correct because diastolic dysfunction affects both phases of filling, not just the early phase. And the late phase, which is the atrial kick phase, is often a compensatory mechanism. So this answer oversimplifies the problem. And letter D, it states the ejection fraction is 50% and the heart fills more slowly during the late phase. This is also incorrect because it suggests that the heart only fills slowly during the late phase. Now, while the late phase can be affected in diastolic dysfunction, it's the whole diastolic phase, both early and late, that is impaired. So this doesn't accurately describe the condition. Now, for you to answer this question correctly, and I want you to remember that diastolic dysfunction is a problem of filling, not about pumping. So you need to pay attention to the ejection fraction. If it's preserved, such as normal range, and so you're likely dealing with diastolic dysfunction. Now, if it is reduced, I'm talking about the ejection fraction. If it is reduced, it's probably systolic dysfunction. And in this case scenario, you have to look for the clues like heart fills more slowly. And you have to make sure the answer addresses both the ejection fraction and the issue with the filling phase of the heart. 8. A client is undergoing Holter monitoring to assess for rhythm abnormalities. What instruction should the nurse provide? Options: A, maintain a log of daily activities while wearing the monitor. B, detach the electrodes before bathing or showering. C, increase physical activity more than usual during monitoring. And D, upload the recorded data to a computer once per day. The answer is letter A. So when a client is undergoing a Holter monitoring, the main goal is to assess their heart rhythm over a time of 24 hours, even 48 hours, to identify any abnormalities that might not show up during a brief EKG. And one of the key aspects of this monitoring process is keeping a log or a diary of those daily activities and symptoms. And so letter A will allow the client to document their activities and document any experiences like palpitations, maybe dizziness or chest discomfort, and the time when these symptoms occur. And the log or the diary can also help the healthcare provider to correlate any rhythm abnormalities with these specific events, which is very critical for diagnosing the underlying cause and also in determining the best treatment plan. Now, why is letter B incorrect? Detaching the electrodes before bathing or showering. Well, the standard here is that the electrodes should not be detached during the monitoring process. And the purpose of the Holter monitor is to provide continuous ECG recordings. And when the client removes the electrodes during the recording, this could interrupt the process. Also, while it's true that bathing or showering should be avoided because the electrodes should not get wet, well, patients can still do sponge bath to maintain hygiene without disturbing the monitoring process. So basically, they have an option to do that. Now, what about letter C? This is also an incorrect option because patients with the Holter monitoring device should maintain their normal activity levels during the monitoring. And the goal of the Holter monitoring is to capture the heart's rhythm under normal everyday conditions. And when you're increasing their physical activity, or if the patient increases their physical activity than their normal daily activities, this can lead to misinterpretation of the normal heart responses to exercise as abnormal rhythms, which could also skew the results. Now, what about letter D? This is another incorrect option. It's because typically the Holter monitor can record the data continuously for the duration of the monitoring, and it does not require daily uploads. Now, the recorded data is generally analyzed after the monitoring period ends, and some advanced event monitors may allow real-time data transmission, but this feature is not common for standard Holter monitoring. Now, for you to answer this question, such as this one, like Holter monitoring devices, I want you to focus on the primary function and the understanding about what the device does to ensure the accurate data collection. Now, the critical aspect of Holter monitoring is continuous recording. And the log is very critical for correlating those symptoms and activities with any rhythm abnormality. So for this question, I want you to avoid those options that suggest removing the monitor or changing activity levels or disrupting the continuous data collection process. So always keep in mind the importance of routine and consistency in monitoring to ensure the accurate results. Number 9, the nurse is caring for a client showing symptoms of an acute myocardial infarction. Which lab test should the nurse prepare to draw in order to assess myocardial cell death? Options: A, troponin I, B, CKMB, C, potassium, D, creatinine kinase. The answer here is letter A. Now, when a client shows any signs of acute MI, your main goal is to assess whether there has been damage to the heart muscle. That's why the correct answer here is letter A. That's troponin I, because this is a protein that is most specific marker for myocardial cell death. And the troponin I is released into the bloodstream when the heart muscle is damaged, and it can be detected 7 to 14 hours after the onset of chest pain. And this makes it an early and reliable marker for diagnosing an early acute myocardial infarction, particularly in the first few hours following the event. Now, why is letter B incorrect? We know that CKMB is a specific isoenzyme of creatinine kinase that may also indicate myocardial injury. But this test is not as specific compared to the troponin I. Now, I want you to remember that CKMB peaks earlier, usually within 4 to 6 hours of chest pain, and it returns to the normal range more quickly, let's say within 48 hours. So it's going to make it less reliable for detecting myocardial necrosis over a long period. Now, we know that it is useful in the acute phase, but not the best for ongoing monitoring or assessing the myocardial damage over time. Now, why is letter C incorrect? Well, potassium is not specific to myocardial infarction. And we know that abnormal potassium levels can indeed be seen in acute MI, especially with clients with arrhythmias or electrolyte imbalances. But these are not going to be a direct indicator of myocardial necrosis. And potassium monitoring is more relevant for the assessment of electrolyte imbalances, but it does not help in confirming the presence or the extent of the heart muscle damage. Now, what about letter D, creatinine kinase? This is also an enzyme that can be found in many types of muscle tissue, including the heart, skeletal muscles, and the brain. And even though CK levels indicate muscle damage, but this is not really specific to the heart. The CKMB isoenzyme would be a better marker if we are trying to assess for myocardial injury, but it still would not be as specific compared to troponin I. Now, the main key takeaway in answering this question is also to focus on the specificity of the test for the myocardial damage. Now, for any myocardial injury, troponin I is the gold standard because it's the most specific and it's sensitive to the heart muscle damage. And I want you to be mindful of the time factors, especially for troponin I, which is a reliable marker for detecting myocardial injury later in the process, which is 7 to 14 hours after the symptoms start. Whereas the CKMB, it peaks earlier, but it is less reliable over time. And I want you to keep in mind that the potassium and CK are also not specific to diagnose myocardial infarction directly. 10. A client is admitted with acute shortness of breath and the nurse suspects heart failure. Which diagnostic test would provide the most definitive evidence for this condition? Options. A. Measurement of B-type natriuretic peptide levels. B. Analysis of arterial blood gases. C. Evaluation of serum troponin levels. D. Assessment with a 12-lead ECG. The answer is letter A. Now, when a patient presents with an acute shortness of breath, it is very critical for you to pinpoint whether the underlying cause is heart failure or maybe another condition such as a respiratory issue. And the correct answer here is letter A, because the measurement of B-type natriuretic peptide is a good indicator because it's a biomarker that is going to be released when the heart's ventricles experienced increased pressure, such as congestion, or there is way too much fluid circulating in the bloodstream, which is a hallmark of heart failure. Now, when the heart is not pumping effectively, as it does in heart failure, the BNP levels rise, typically more than 100 picograms per ml. And this elevation is a strong reflection that the heart failure is contributing to the shortness of breath, making the BNP testing a key diagnostic tool to differentiate heart failure from other conditions like COPD or maybe pneumonia. Now, why is letter B incorrect? Analysis of ABGs. We know that this could provide important clues since it measures oxygenation and acid-base imbalance, but this is not going to detect what really the cause is, right? Conditions like pneumonia or COPD can also present with similar results, so ABGs are not useful in directly diagnosing heart failure. Now, what about letter C? Evaluation of serum troponin levels. This is primarily used to detect myocardial injury, particularly in acute MI. And we know that heart failure can cause mild troponin elevation due to the stress on the heart, but troponin is not a specific marker for heart failure itself. This is much more helpful for ruling out MI in a patient who might have both conditions, but it would not be the go-to test for heart failure diagnosis. Now, what about letter D, 12-lead ECG? Well, this is a test that can reveal a variety of abnormalities, maybe arrhythmias, ischemia, or left ventricular hypertrophy, which are common in heart failure. But an EKG cannot definitively diagnose heart failure. It can provide useful information about cardiac rhythm and structure, but it does not specifically confirm the heart failure as the cause of the symptoms. So, Your key strategy to answer this question is to understand the specificity of the diagnostic tool. And when you encounter this type of question, always prioritize tests that are specific for the condition you're trying to identify. And again, the BNP is the only test that is specifically linked to the heart failure. 11. While the nurse is conversing with the client, the monitor shows signs of ventricular fibrillation. What should the nurse do next? Options. A. Assess the client and check the monitor leads. B. Initiate advanced life support protocols as soon as possible. C. Immediately defibrillate the patient. D. Begin basic life support protocols and call for assistance. The answer here is letter A. Why is this correct? Now, when you encounter a situation like this one, wherein the monitor shows signs of ventricular fibrillation, it is critical for you to take a step-by-step approach to confirm first the situation before you jump into life-saving actions. And so in this case, the answer is letter A, because the client is still speaking, right? And show signs of cardiac output, such as being conscious. So this means this might not be a true ventricular fibrillation. We know that VFib is a life-threatening arrhythmia that leads to no pulse and no cardiac output, which would make the patient unresponsive and without a pulse. But since this patient is speaking, the nurse needs to assess first whether the leads are properly connected to the client or if there is some electrical interference that's causing a false alarm. And sometimes loose leads or maybe external interference can create a rhythm on the monitor that looks like VFib, but it's not a true emergency. So your first step here is to check the leads and to confirm the patient's condition, which is the most appropriate initial step. Now, what about letter B? Initiate advanced life support protocols as soon as possible. Now, before you jump into doing advanced life support, your role here is first to confirm that the rhythm shown on the monitor is actually VFib. Now, if you start the ACLS protocols right away without confirming the rhythm, it might delay the appropriate response, and this can cause unnecessary intervention. And the first step is always confirmation of the rhythm, which means assessing the patient and checking the leads. Now, what about letter C? Why is this incorrect? We know that defibrillation is the definitive treatment for ventricular fibrillation, but it should only be administered if the nurse is sure that the patient is indeed having ventricular fibrillation. And so, given that the patient is still speaking and appears to be alive, it's unlikely they are experiencing true ventricular fibrillation. And when you're defibrillating the client without confirming the rhythm, this could lead to harmful effects to your client. So the first action should be always to assess the patient and check for any issues with the leads, not defibrillate right away. So pay attention to the case scenario. It's stated the nurse is conversing with the client. All right. So the client is not out, not unconscious, not pulseless. Now, what about letter D? Begin basic life support protocols and call for assistance. We know that the basic life support, or BLS, should be initiated if the patient is unresponsive or not breathing. But in this case, the patient is still speaking and has cardiac output. So this means they are likely not in full cardiac arrest. And the assessment of the patient, first thing is the priority to ensure that there are no signs of a true emergency like a lack of pulse. And this is the best approach before you consider BLS. And this BLS would be necessary only if the client is unresponsive or if they are showing signs of cardiac arrest after a thorough assessment. So for you to answer this question correctly, I want you to prioritize in assessment before you jump into the interventions. And always take a moment to verify the condition of the patient before you respond to extreme interventions. Now, the monitor may be giving a false alarm due to possible loose leads or interference, and so confirmation of the patient's status and the accuracy of the reading should always comes first. Let's have number 12. While receiving a 12-lead ECG for a 68-year-old client undergoing a routine physical exam, which finding should the nurse identify as the most concerning? Options: A, heart rate of 42 beats per minute. B, QRS complex duration of 0.13 seconds. C, PR interval measuring 0.21 seconds. D, presence of a right bundle branch block. The correct answer is letter A. Now, in this case, when you're reviewing the 12-lead ECG of this 68-year-old client, take note about the age. You have to be vigilant about the changes that could indicate an urgent issue. Now, why is letter A the correct option? This is basically severe bradycardia, right? Now, for older adults, a heart rate that low could be indicative of a significant issue, such as sinus bradycardia, which can result from age-related changes in the conduction system, or could be due to the medication side effects like beta blockers or calcium channel blockers, or even conditions like sick sinus syndrome, or maybe heart block or hypothyroidism. Now, this bradycardia can cause symptoms like dizziness. It can lead to syncope, hypotension, and also a reduced cardiac output. So it's critical for you to evaluate this finding immediately. Now, if this is not addressed promptly, the severe bradycardia can progress. It can worsen to more serious complications. And so that is why this is something that you should consider, and as the most concerning option for this case. Now, what about letter B, QRS complex duration of 0.13 seconds? Now, I want you to remember the QRS complex duration here is slightly prolonged, but this is not so alarming. And recall that the normal duration of a QRS complex is less than 0.12 seconds, and the duration of 0.13 is mildly prolonged. So this might suggest a bundle branch block or maybe age-related changes in the conduction system, but it is not the most concerning finding in this context. Now, we know that mild prolongation like this doesn't usually cause immediate clinical issues unless it's more significant, let's say greater than 0.14 seconds. So it's not really a priority. Now, what about letter C? PR interval measuring 0.21 seconds. Now, a PR interval of this duration is slightly prolonged because the normal range is 0.12 to 0.20 seconds. And this one could indicate a first-degree atrioventricular block, which is often a benign, especially in older adults. But it doesn't typically cannot lead to symptoms or can require an urgent intervention. And this is a common finding and generally not a cause for concern unless the interval becomes significantly longer or is associated with other manifestations. That's why you're going to get rid of this option. Now, what about letter D? Presence of a right bundle branch block, which is a common finding in the older adults, and this may be a benign if there is no underlying heart disease. And the right bundle branch block can be seen in older adults and can often doesn't cause significant issues. And this is something that is seen in normal aging or in conditions like hypertension or coronary artery disease, or if there is cardiomyopathy or pulmonary issues like COPD. And the right bundle branch block typically is benign unless it can lead to symptoms or associated with more severe heart conditions. And so in the absence of acute symptoms, it is not something that requires immediate interventions in this case. Now, so the main key takeaway in answering this test question is to consider about the severe bradycardia. This is the most concerning finding, and this should be assessed promptly and further. And I want you to take note about the QRS complex of 0.13 seconds, which is typical in older adults, and it's not urgent. And the PR interval of 0.21 seconds as well. And we have the presence of the right bundle branch block, which are often incidental unless they are associated with a significant symptoms or possible heart disease. Now, for you to answer this question correctly, always prioritize symptoms and signs that can reflect impaired circulation or oxygenation, like severe bradycardia. Now, if a finding could compromise cardiac output, or let's say oxygen delivery, like dangerously low heart rate, this is something that you should address first. Now, on the other hand, those other mild changes in conduction, such as slightly prolonged QRS and PR interval, these often reflect normal aging and generally are less urgent unless they cause any symptoms. 13. A client presents with lightheadedness and a fluttering feeling in the chest. The nurse places the client on a heart monitor and observes an atrial tachycardia with a heart rate of 160 beats per minute. The client's blood pressure has dropped from 128/76 to 92/46, but remains stable at the lower level. What should the nurse do next? Options: A, call the provider and prepare the client for medical or electrical cardioversion. B, prepare the client for asynchronous defibrillation. C, withhold beta blockers and calcium channel blockers. D, give the client digitalis IV and then call the provider. The answer here is letter A. Now, in this case, the client is presenting lightheadedness, which is a classic manifestation of this rapid heart rate, and also reported fluttering, feeling in the chest, and a heart rate of 160 beats per minute due to the atrial tachycardia. Also pay attention to the blood pressure of 92/46, right? This is a huge drop from the original reading of 128/76. And this actually indicates some level of hemodynamic instability due to the rapid heart rate. And the combination of the symptoms here, the tachycardia and the low blood pressure actually suggests that the heart rate is not only abnormally high, but it's also insufficient to adequately maintain the cardiac output. And so this led to the client reporting dizziness and fluttering feeling in the chest. Now, why is A the correct answer? Well, whenever a client is symptomatic and if the heart rate is excessively high, which is over 150, right? Such as in this case, cardioversion is the necessary intervention to restore the normal rhythm to avoid further complications, such as hemodynamic collapse. Now, take note that the client is already symptomatic. There is lightheadedness, fluttering sensation, and there is a sudden drop of the blood pressure. So the emergent cardioversion is the critical appropriate step here. Now, it said something about medical or electrical cardioversion. Well, medical cardioversion simply means that it's going to involve the use of medications like adenosine, or let's say electrical, which uses synchronized shock to reset the heart's rhythm. And your role here as a nurse is to prepare the client for this intervention while notifying the provider to ensure a timely intervention. Now, what about letter B? Why is this incorrect? Prepare the client for asynchronous defibrillation. This is basically referred as the defibrillation, which is used for more severe arrhythmias such as ventricular fibrillation or pulseless ventricular tachycardia, where there is no organized rhythm or pulse. So, in contrast, The atrial tachycardia that you are seeing in this case is still an organized rhythm. It's fast. So synchronized cardioversion, which delivers a shock in sync with the heart's rhythm, is the preferred treatment for atrial tachycardia. Now, defibrillation is totally different. This would be inappropriate for this case because it could cause harm, because it can disrupt the normal rhythm. Now, what about letter C? Withhold beta blockers and calcium channel blockers. These are meds that are supposed to control the heart rate in atrial tachycardia. And these two medications can also slow down the conduction through the AV node, and this can help manage the tachycardia. And so if you are withholding these medications, this could allow the heart rate to remain dangerously high, which can actually worsen the patient's condition. So this is something that you should discard. Now, what about letter D? Give the client digitalis IV and then call the provider. Well, I want you to remember that digoxin or digitalis can be used to treat certain arrhythmias like atrial fibrillation or atrial flutter with rapid ventricular response, but this is not typically the first line treatment for atrial tachycardia. Now, I want you to remember that digitalis has a narrow therapeutic range. Simply means that it can cause toxicity if not monitored closely, and it's not the ideal choice in this scenario. And it also takes longer to work, so it's not the most urgent intervention this time. So for you to correctly answer this question, I want you to remember that atrial tachycardia, and if this is associated with the following manifestations, it simply means that there is hemodynamic instability, which requires emergent cardioversion, which is why you need to prepare the client for this intervention. Now, again, synchronized cardioversion is preferred over defibrillation in atrial tachycardia. And also take note that withholding the beta blockers and the calcium channel blockers can harm the client all the more. So let's have number 14. The nurse is reviewing a rhythm strip and notices that the QRS complex is 3 small boxes wide. How should the nurse interpret this measurement? Options: A, 0.04 seconds, B, 0.16 seconds, C, 0.12 seconds, and D, 0.10 seconds. The answer here is letter C. And why is that? Now, when you're reviewing an ECG rhythm strip, I want you to understand first how to measure the width of the QRS complex accurately. And in this question, you had observed that the nurse observed that the QRS complex spans 3 small boxes on the strip. So let's break down into why letter C is the correct answer. So I want you to review here about the boxes. Take a look into the small boxes here. So basically each small box that's 1 millimeter, it's equivalent to about 0.04 seconds, right? So to determine how long the QRS complex is, you need to simply multiply the number of the small boxes it spans by the time of the duration of each small box represents. So in this case, the QRS complex spans 3 small boxes. 1, 2, 3. So here's a simple math. So 3 small boxes, and then you just multiply it by the amount of seconds per box. So that yields 0.12 seconds, right? So the correct interpretation of the QRS complex width here is 0.12 seconds. And this measurement falls within the normal range of the QRS complex, which is typically 0.6 or 0.06 rather to 0.12 seconds. And if in case a QRS duration is longer than 0.12 seconds, this could suggest a delay in the QRS or in the conduction, possibly an indication of a bundle branch block or maybe some other form of conduction issue. And so if you selected letter A, if you selected letter A here, this says 0.04 seconds. What does that mean? It's a bit shorter, right? So this would only be the width of one small box, not three. So this answer doesn't make sense in the context of the QRS complex spanning 3 boxes. And letter B, 0.16 seconds. This would be the width of the 4 small boxes. 0.04 seconds, you multiply it by 4 boxes. And since the QRS complex is only 3 boxes wide, this is not the correct answer. Now, what about letter D, 0.10 seconds? This is quite close, but it's not correct. For the 0.10 seconds, the QRS would need to span 2.5 small boxes, which is not the case here. And the strip shows 3 boxes, so the duration is 0.12 seconds, not 0.10 seconds. I hope that you got this one. Number 15. A nurse is preparing a client for cardiac catheterization with coronary angiography. What information should the nurse provide before the procedure? Options. A warm or flushed sensation may occur when the contrast dye is injected. B, continuous arterial pressure monitoring will be necessary for 24 hours after the test. C, the client must remain completely still throughout the entire procedure. D, sedation with monitored anesthesia care will be administered during the test. The answer here is letter A. Well, before we go into the rationale, when you are preparing a client for a cardiac cath with coronary angiography, you need to provide clear information to your client to ensure the client is informed and also will experience less anxiety during the procedure. And that is why letter A is the correct answer. You should explain that a warm or flushed sensation may occur when the contrast dye is injected. This is a expected sensation. And during the procedure, the iodinated contrast dye is injected into the vein, and this will also actually not vein, but the coronary arteries rather. This will allow the healthcare provider to visualize the blood flow to the heart. And this is a common side effect of this injection, and this is a temporary warm flushed sensation, and this is often felt in the face and the chest area. And in some cases, patients may even feel a transient urge to urinate. And so informing them about these expected sensations would help the client reduce their anxiety and to prevent any surprise during the procedure. Now, why is letter B incorrect here? It said continuous arterial pressure monitoring for 24 hours. Well, this is not accurate. We know that continuous arterial pressure monitoring might be required for patients who are critically ill or have undergone high-risk interventions, but it is not typically needed for patients after a routine diagnostic cardiac catheterization. And usually, patients only will require brief monitoring, let's say 1 to 6 hours in the recovery area. And if there are no complications, the client can often be discharged the same day. Now, why is letter C incorrect? It stated the client must remain completely still throughout the entire procedure. This is not entirely correct. While the client must remain still during the catheter insertion to prevent vessel injury, they are not required to stay completely immobile for the entire procedure, because the cardiologist may ask the client to cough, or they also ask the client to take deep breaths at certain points to help with the imaging and also to manage issues like transient bradycardia. And clients in this type of procedure are typically awake and also responsive during the procedure unless there is some form of sedation given. Now, what about letter D? Sedation with monitored anesthesia care will be administered during the test. This is incorrect because this monitored anesthesia care involves deeper sedation, often with the use of a propofol. And this is not usually required unless the patient is unable to tolerate being awake during the procedure. And for most patients, minimal to moderate sedation is sufficient to help them relax. And the use of the medications like midazolam and fentanyl are commonly used. And the use of the general anesthesia is rare and only being necessary in certain high-risk cases like transcatheter or maybe valve replacement. And so the main key takeaways in this question, make sure that you recall about that expected sensation. And this should be explained to your client before the procedure. And take note about this, continuous arterial pressure monitoring. It's not typical unless the client is critically ill. And letter C is also incorrect. They're not supposed to completely be immobile during the entire procedure because they are going to be instructed to cough or maybe take deep breaths. And the use of minimal to moderate sedation is usually enough. And monitored anesthesia care is not really something that is expected in most cases. Number 16. A client reports discomfort in the center of their chest along with nausea. After the nurse requests a 12-lead ECG, the results show a newly elevated ST segment into adjacent leads. What is the nurse's next action? Options. A. Continue monitoring the client as the ST segment changes are not significant. B. Observe the client for worsening gastrointestinal symptoms. C. Contact the healthcare provider immediately as the elevated ST segment may indicate heart damage. D. Reassure the client that the ST segment changes are normal. The correct answer here is letter C. And why is that? Well, when the client is reporting any chest discomfort or maybe nausea combined with the new elevation of the ST segment of the adjacent leads, this is reflecting a potentially serious condition. And so this could indicate an acute myocardial injury or maybe ischemia, or could be conditions that require immediate interventions. And so the key clue in this question is the newly elevated ST segment, which is often a sign of heart damage, something that you will see in myocardial infarction. So your appropriate intervention or response is to contact the healthcare provider immediately because the ST segment elevation could suggest that the heart is not getting enough oxygen and you will need urgent treatment to prevent further damage to the heart muscle. Now, what about letter A? Continue monitoring the client as the ST segment changes are not significant. Well, this is a risky approach because new ST segment elevation is significant and this needs immediate attention. And so if you're just monitoring without action, this is actually delaying the necessary treatment. For letter B, observe the client for worsening gastrointestinal symptoms. We know that nausea can be associated with heart problems. And so the priority here is to address the possible myocardial injury, not GI symptoms. Now, letter D is also incorrect. Reassure the client that the ST segment changes are normal. No. ST segment elevation is not normal, and this is a sign that something serious is happening, such as a heart attack. And so this is misleading your client, and this can also delay any critical care. So when you're going to encounter this type of question, always focus on the urgency and the patient's safety. And when a patient presents with chest pain and ECG changes, heart injury should always be considered, and any other signs of possible MI or muscle damage require immediate action. So I want you to avoid those options that suggest inaction or, let's say, downplaying the symptoms, which can delay any critical treatment. 17. A client with CHF has peaked T waves on the ECG. Which laboratory value should the nurse evaluate? Options: A, potassium level; B, troponin level; C, creatine kinase; MB, D, B-type natriuretic peptide, or the BNP. The answer is letter A. Why is letter A the correct answer? Now, when you are going to see peak T waves on the ECG, this is a clear indicator that the client may have developed hyperkalemia. And take note that the potassium plays a critical role in the electrical activity in the heart. However, if there is too much of the potassium, such as greater than 5.5, this can interfere with the heart's electrical system. It can lead to dangerous arrhythmias, which could be life-threatening. Now, in this client with a congestive heart failure, the hyperkalemia can happen maybe due to the renal impairment because the kidneys are not working as well due to the poor blood flow, and maybe due to the use of potassium-sparing diuretics such as spironolactone, or could be the use of the angiotensin-converting enzyme inhibitors that may prevent potassium from being excreted properly. And so when you see those peaked T waves, your next step is to check the potassium level right away. So this is the most critical lab value to evaluate. Now, I want you to pay attention to the different levels of the potassium or levels of hyperkalemia, because actually it's not just peak T waves that you can see in hyperkalemia. There are so much more. And so reviewing this with the EKG, take a look here when there is normal potassium. So your EKG basically looks like this. You have all the expected waves right there. However, when there is going to be mild hyperkalemia, such as in the case of 5.5 to 6.5 milliequivalents per liter, what you're going to see here is that the T waves will become tinted, right? So why is this happening? Well, it's because the excess potassium in the blood causes faster repolarization, or basically causing a rapid return to the cardiac cell's resting state, specifically after or specifically affecting the T wave, which reflects that the repolarization or resetting of the ventricle. So this is often the first noticeable sign of hyperkalemia. We're talking about mild hyperkalemia. Now, whenever there is moderate hyperkalemia, such as in the case of 6.5 to 8 milliequivalents, the ECG will look like this. And whenever the potassium rises to this range, the effects on the heart become more pronounced. So you will be seeing widening of the QRS complex, all right? Which represents the time that it takes for the ventricles to contract after the electrical impulse arrives. And so the elevated potassium can slow down this electrical conduction. So it makes the ventricles take longer to respond to the signal. Now, the PR interval, which is the time from the atrial contraction to the ventricular contraction, also gets prolonged. And this is something that's going to happen because the potassium affects the atria and the AV node, which the electrical relay station between the atria and the ventricles, and this can cause delayed transmission of the electrical signals. And so in this moderate hyperkalemia, you're going to start to see more noticeable effects on the heart's ability to conduct electrical signals, which makes the ECG look more abnormal. So don't forget, moderate hyperkalemia, there's going to be widening of the QRS complex. Now, if the potassium goes severely high, such as greater than 8 milliequivalents per liter, there's going to be loss of P waves. You're not going to see that anymore. You will see that sine wave pattern this is going to place the client at risk for cardiac arrest. And the P waves again are lost. This basically is the P wave, as we know, in the normal EKG, reflects atrial contraction, but this is now disappearing because the atria can no longer effectively contract or maybe generate a normal electrical impulse due to the high potassium. And so this indicates a severe disruption in the heart's rhythm. Now, why is the client going to have a sine wave pattern? Well, this is basically appearing as a fusion of the QRS complex and the T wave. Basically the blending of the ventricular depolarization and the repolarization into one irregular undulating waveform. And so this basically indicates that the heart's electrical activity is completely out of sync, and it suggests a very dangerous state of electrical instability. Now, there is a risk of cardiac arrest whenever there is severe hyperkalemia, and the heart becomes so electrically unstable that it can stop beating effectively. Now, why are all these changes happening? Well, we know that potassium affects how electrical impulses move through the heart, and when the potassium levels rise, they make the cells of the heart more excitable. This can lead to changes in the waveforms and slow down the conduction of the electrical signals. This can lead to the prolongation of intervals like the QRS and the PR. And in severe cases, the heart may no longer be able to function properly, which is why high potassium levels are so dangerous, and this can lead to fatal arrhythmias or cardiac arrest. And so, in short, mild hyperkalemia, pay attention to peak T waves reflecting faster repolarization. Now, with moderate hyperkalemia, there is prolonged conduction between or in the QRS and also prolonged PR interval. Now, with a severe hyperkalemia, there is loss of P waves, there is sine wave pattern, and high risk for cardiac arrest. And so, the nursing action here, especially if you have, let's say, mild hyperkalemia, you're going to have to review, of course, when you have this T waves. Again, in our case, it said something about evaluating the laboratory value of the potassium, right? However, if you have the worse forms of hyperkalemia, such as this one, the patient could probably require the administration of the D50 with the insulin, or could be with the use of the calcium gluconate for the for the moderate hyperkalemia to decrease the irritability of the heart cells, and possibly they're gonna need to take the kayexalate as well, which is that exchange resin to eliminate the excess potassium in the bloodstream. Now, why is letter B an incorrect option in this case? Although troponin is an important diagnostic test in identifying MI, but it doesn't cause peaked T waves. Now, if there were signs of chest pain or ST segment elevation, then troponin would be key in diagnosing the client, but not in this case where hyperkalemia is the primary concern. Now, what about letter C, creatinine kinase MB? This is another marker for cardiac injury, especially for MI, but it doesn't lead to changes like peaked T waves. And the CK-MB troponin and the elevation would not explain the ECG changes as well. Now, for letter D, B-type natriuretic peptide, or the BNP, is also useful in diagnosing heart failure because it's elevated when the heart is struggling with the fluid overload, but the BNP does not affect the ECG directly, and it's not related to the elevation of the T waves. Let's have number 18. The nurse is analyzing a client's cardiac rhythm and observes that the PR interval is 0.16 seconds. Based on this finding, the nurse should interpret the PR interval as indicating A, slower than normal conduction from the SA node through the AV node, B, abnormally fast depolarization of the atria and ventricles, C, faster than normal conduction from the SA node through the AV node, D, normal conduction from the SA node through the AV node. The answer is letter D. Now, when you're analyzing a cardiac rhythm, one of the things that you have to focus on is the PR interval, which reflects the time it takes for the electrical impulse to travel from the SA node through the AV node. And this is the area that helps regulate the impulses between the atria and the ventricles before it reaches the bundle of His and the rest of the conduction system. And so this interval essentially gives us an insight into the conduction speed between the atria and the ventricles. Now, the key point here is the normal range for the PR interval, which is typically between 0.12 and 0.20 seconds. And now, your client's PR interval is set at 0.16 seconds. And this interval falls right within the normal range. So it indicates that the conduction from the SA node through the AV node is occurring at a healthy rate. So that's why it is the answer. Now, what about letter A? Slower than normal conduction from the SA node through the AV node. Now, if the PR interval were longer than 0.20 seconds, that would indicate slower conduction from the SA node through the AV node. However, since the PR interval here is 0.16 seconds, which is normal, this is not the case, and this is a key clue. The PR interval would be longer if conduction was slower, not within the normal range. And letter B, also an incorrect option. The fast depolarization is not related to a normal PR interval. In fact, abnormally fast depolarization usually happens in a shortened PR interval, not one that's normal. And this is something that you will typically see in conditions where the atria or the ventricles are overexcited. It can lead to a shorter PR interval than normal. So this answer can be ruled out. Now, what about letter C? If the conduction through the AV node were faster than usual, then we'd see a shorter PR interval, which is less than 0.12 seconds, not a normal 0.16 seconds. So this is a critical clue. Faster conduction usually leads to a shortened interval, not one that is normal. So in order for you to answer this question correctly, I want you to remember the normal range of the PR interval, which is 0.12 to 0.20. Okay? So you have to focus on what is normal and use that to guide you through the question. 19. A nurse at the nurse's station notices that a client's telemetry monitor shows ventricular fibrillation. What is the nurse's immediate action? Take note of the question stem. A nurse at the nurse's station notices that a client's telemetry monitor shows VFib. Options: A, initiate CPR. B, activate the code team. C, get ready to perform defibrillation. D, administer an IV push of epinephrine. The answer is letter B. Why is that? Now, again, like I have said, as I've emphasized already in the case, when the telemetry monitor shows VFib, the first thing that comes to mind is that this is a life-threatening arrhythmia, and the heart is not pumping blood effectively, which means immediate intervention is very critical. Now, in this case, the nurse is stationed remotely at the nurse's station. So their action must be aligned with getting help and definitive care to the patient as quickly as possible. Now, activating the code team focuses on the most efficient action. And since the nurse is at the nurse's station and doesn't have access first to the patient's bedside equipment like a defibrillator, the most effective way to address VFib here is to call a stat code. So this can actually trigger the emergency response. It will bring the code team to the bedside with the necessary equipment, defibrillator, crash cart, to handle the situation. Now, the priority here is ensuring that the patient gets defibrillation and other immediate care as soon as possible. And so time is critical in VFib, and calling the team is the fastest, and this is the most effective way to address this issue. Now, why is letter A incorrect in this case? We know that CPR is essential in VFib because it can maintain circulation when the heart is not pumping blood. However, the nurse is at the station, not at the bedside, so they cannot immediately start CPR. Even if the nurse were to run to the patient, it would still delay the process of getting the defibrillator to the patient, which is the most critical intervention for VFib. And CPR and defibrillation go hand in hand in a code situation, but getting the code team to the bedside as quickly as possible is more important than trying to perform CPR alone from a distance. Now, what about letter C? Get ready to perform defibrillation. We know that defibrillation is also the definitive treatment for VFib. However, the big however here, the nurse is at the nurse's station and cannot perform defibrillation themselves since they don't have the direct access to the defibrillator or the patient. And to try and get ready to perform this action would require the nurse to leave the station, which delays their response time. And so activating the code team is the priority because it mobilizes the team with all the necessary equipment to provide the immediate defibrillation. Now, why is letter D incorrect? Administer an IV push of epinephrine. We know that epinephrine is part of the ACLS protocol, and this is used after initial defibrillation to support circulation. However, epinephrine is not the first action in VFib. This is something that's given after defibrillation attempts and typically every 3 to 5 minutes during the CPR. And since the nurse is not at the bedside, they can't give the IV push anyway. And so the immediate need here is defibrillation, not medication. Therefore, this option is delaying the urgent need for defibrillation and is not the best first step. Now, your key strategy to answering this question is to understand the time, which is of the essence here when it comes to treating VF. And so in a situation where the nurse is not at the bedside, the priority is to get the team and equipment to the patient as quickly as possible. And so this is where the test clue comes. The nurse's position at the station makes it impossible to perform hands-on interventions like CPR or defibrillation. Simply do something that you can do right away. Calling or activating the code team is that quick. All right. So this can ensure that the patient will receive the fastest and most comprehensive care. Let's have number 20. The nurse is reviewing a client's echocardiogram report, which notes hypertrophy of the ventricular septum. Which type of cardiomyopathy is most likely associated with this finding? Options: A, dilated, B, restrictive, C, hypertrophic obstructive, D, congestive. The answer here is letter C. So when you're reviewing a client's echocardiogram report that notes hypertrophy of the ventricular septum, your first thing to do is to focus on the specific feature of hypertrophy that is mentioned. And so this tells us that the heart septum, which is basically the wall between the left and the heart ventricles, is thickening, which is the defining characteristic of a particular type of cardiomyopathy. And so that's why letter C is the correct answer. Okay, this is the form of cardiomyopathy most commonly associated with ventricular septal hypertrophy. Hypertrophy basically is that there is now a enlargement of the septum. And again, this is the thickening of that divider that can lead to the obstruction of the blood flow, particularly in the left ventricle. Now, this is also a structural issue that is mostly closely tied to the specific hypertrophy. And the key clue here is the ventricular septum, right? Which directly points to the hypertrophic obstructive cardiomyopathy. Now, why is dilated type the incorrect option here? Why is A incorrect? Well, this type involves the dilatation or enlargement of the heart's chambers, particularly the ventricles. So instead of hypertrophy, The dilated cardiomyopathy results in a weakened heart muscle that struggles to pump blood, and it is the opposite of the hypertrophy, so it doesn't match the finding of ventricular septal hypertrophy. Letter B, restrictive, is also incorrect because the restrictive cardiomyopathy basically reflects that the heart muscle becomes stiff, particularly the ventricles, which restricts the heart's ability to fill properly during the diastole. However, septal hypertrophy is not a typical feature of this condition, and instead, the problem lies more in the diastolic dysfunction due to the stiffness of the muscle, not the thickening of the septum. Now, why is letter D incorrect? Congestive. Well, the term congestive cardiomyopathy is not recognized or specific type of cardiomyopathy, and the more appropriate term would be congestive heart failure, which is a condition that results from other forms of cardiomyopathy, but it is not a type of cardiomyopathy itself. So disregard this option because it doesn't refer to a distinct cardiomyopathy option. So your strategy to answering this question is to carefully identify the key terms of the question, like hypertrophy of the ventricular septum, and you have to match that with the cardiomyopathy type that is most associated with it. Let's have number 21. A client presents with multifocal premature ventricular contractions. Which antidysrhythmic medication is most likely to be prescribed by the healthcare provider? Options: A, digoxin; B, adenosine; C, amiodarone; D, atropine. The answer is letter C. That's amiodarone. And so when your client presents with a multifocal premature ventricular contractions, the primary goal of the treatment is to stabilize the ventricles and also to reduce the abnormal beats that originate in the various places within the ventricles. And so that's why letter C is the option. And amiodarone is that class 3 antidysrhythmic that works by prolonging the cardiac action potential and the refractory period. And so the purpose of the amiodarone is to stabilize the heart. It will reduce abnormal electrical impulses, specifically those originating from the ventricles, which is precisely the problem in multifocal PVCs. And the amiodarone is also effective in treating ventricular arrhythmias, including premature ventricular contractions, especially when they are frequent or symptomatic. And in the emergency settings, amiodarone is often administered IV to act quickly and effectively. Now, why is letter A incorrect? We know that digoxin is a cardiac glycoside. It increases contractility and also it slows the atrioventricular node conduction. And this is something that you would expect in cases such as atrial fibrillation or heart failure, but it does not directly address ventricular ectopy like PVCs. And in fact, at high levels, the digoxin can actually increase the ventricular irritability, which could worsen the premature ventricular contractions. And so this is the wrong choice for managing multifocal PVCs. Letter B, adenosine, is a class 5 antidysrhythmic medication to treat supraventricular tachycardias, or we call them as SVTs, by briefly blocking the AV node conduction. And since what we have in our case is multifocal PVCs, these are ventricular, this is a ventricular issue. It's not an SVT. And so adenosine has no effect on these types of abnormal beats. And it's not useful in this situation, making it an appropriate choice for treating the multifocal PVCs. Now, letter D, atropine. What is this? This is an anticholinergic drug that is used to treat bradycardia or atrioventricular blocks where the heart rate is very slow. And this is a medication that blocks the vagus nerve to increase the heart rate. However, the multifocal PVCs are caused by extra ventricular beats, not by a slow heart rate. And since atropine doesn't stabilize ventricular activity, it would not help in this case and could even worsen the problem by increasing the ventricular irritability. And so when you answer this question, your key is to focus on the type of arrhythmia. In this case, multifocal premature ventricular contractions, right? And the mechanism of action of the drugs and targeting the origin of the arrhythmia should be your focus. And since the PVCs originate from the ventricles, you would want to select that option or medication that directly stabilizes the ventricles, like amiodarone, which is designed for ventricular arrhythmias. And I want you to quickly eliminate those wrong options. Think about what the drugs are primarily used for. And so digoxin is used for atrial issues, or CHF. Adenosine is used for supraventricular issues, and atropine is used for bradycardia and AV block. So this will hopefully guide you toward the correct answer. 22. A client under review for a possible myocardial infarction asks the nurse which test is typically used to identify where the heart muscle damage is located. What's the nurse's best reply? Options: A, blood tests for cardiac enzymes; B, electrocardiogram tracing; C, cardiac catherization procedure; D, echocardiogram. The answer is letter B. So when your client suspected of having a heart attack and asks you about the best way to identify where the heart muscle damage is located, your most accurate response would be to point out letter B, right? Why? Because the ECG is the first line test used to identify the location of the MI. It will work by detecting those specific electrical changes that occur when different parts of the heart muscles are damaged. And so, for example, an ST segment elevation in certain leads like leads 2 or leads 3 and lead AVF. So this can point to an inferior MI. And so the ability to pinpoint the region of the heart that is affected makes the ECG very valuable in guiding the treatment decisions, such as whether to use thrombolytics or maybe to perform a percutaneous coronary intervention, or what we call a PCI, or to proceed with medical management. And so the clue in this is to focus on the electrical changes in the heart, and that is the ST segment elevation. Could be T wave inversion, or it could be pathological Q wave. So those are the possible changes whenever there's an MI. And it's also fast, it's non-invasive, and it's widely available, and it's going to be the primary tool that is used in suspected MI cases. Now, why is letter A incorrect? This is blood tests for cardiac enzymes. So we're talking about troponin, CKMB. We know that these are critical for confirming the heart attack has occurred. But again, they don't help with localizing. It will not help identify where the location is for the damage. Now, what about letter C, cardiac catheterization procedure? We know that this is excellent in identifying the blockages in the coronary arteries, but will not show the actual location of the myocardial damage. This is an invasive procedure. It requires scheduling. So it's not really the go-to first test for pinpointing the location of the infarct. All right. Now, what about letter D, echocardiogram? This is a test that provides valuable information about the function of the heart and also can show the wall motion abnormalities caused by the ischemia or the infarction, but it does not directly locate where the infarct is. Okay. It's useful though for assessing the extent of damage after an MI, but it doesn't have the precision of an ECG when it comes to pinpointing the exact area of myocardial injury. And so we don't have a better option here, but letter B. 23. A client admitted with dizziness, breathing difficulty, and chest discomfort has an ECG revealing atrial fibrillation and is set for a TE this afternoon. Which nursing action is most suitable right now? Options: A, help the client walk to the restroom; B, give the client a meal to eat. C, provide oxygen as ordered by the healthcare provider. D, prep the client for urgent electrical cardioversion. The answer is letter C. So in this case, the priority nursing action for this client with the AFib, especially that they are reporting dizziness, there's difficulty breathing, and also some chest discomfort. The goal here, or the priority intervention, is to provide oxygen as ordered. Okay? Why? It's because AFib can significantly impair the heart's ability to pump the blood efficiently. It will lead to decreased cardiac output. It will result to less oxygen delivered to the vital tissues. And so this can cause symptoms such as dizziness, shortness of breath, and some chest pain. And these are all signs of hypoxia, or inadequate oxygenation. And so we don't have a better answer than administering O2 to help increase the patient's oxygen saturation. This will help relieve the dyspnea. This will stabilize the client further while we are waiting for the diagnostic test, TEE, to be done. Now, it's very simple. It's immediate, effective intervention to support the client while they are unstable. And so I want you to go back into the question stem. The client is already reporting dizziness, breathing difficulty, and chest discomfort. These are all signs of hypoxemia. So you should point out right away that the client is basically needing some supplemental O2. Now, why is letter A incorrect? Help the client walk to the restroom. Very bad decision to do this. Well, it simply means that this is a very unsafe action for this client. Remember that they have dizziness, breathing difficulty. And so this can worsen the client's condition. They could potentially fall or could lose consciousness if they exert themselves. And since their heart is not pumping effectively due to the AFib, any activity could worsen their symptoms or even lead to a collapse. And so the priority here is safety and stabilization. So walking should be avoided at all costs. Letter B, give the client a meal to eat. This is inappropriate because the client is scheduled for the TEE. Remember, it requires NPO for at least 6 hours. And letter D, prep the client for urgent electrical cardioversion. Electrical cardioversion involves shocking the heart to restore the normal rhythm. So this is not the first course of action here. And the reason is that before performing cardioversion, the healthcare team needs to ensure that there are no blood clots in the atria. And this is done by performing the TEE first. And so if this happens, if the heart is shocked while a clot is present in the atria, it could dislodge. It can lead to a stroke or a CVA. And the cardioversion is generally reserved for hemodynamically unstable clients, such as those with low blood pressure or unresponsiveness, or in cases like cardiac arrest. So in this case, the client is symptomatic, but still stable enough to first undergo the TEE. Okay, so main key takeaway here is to provide your client some supplemental oxygen, because this can directly address the symptoms of hypoxia. We have a problem with the breathing and the circulation. All right. Walking poses a safety risk. It can worsen the symptoms. The feeding in letter B, it's contraindicated due to the TEE, and the cardioversion should be postponed until the TEE confirms that there are no atrial clots. And so your strategy in answering this question is to prioritize stabilization. You have to do that first. Your client is symptomatic before you move on into the diagnostic or the procedural steps. 24. What instructions should the nurse provide to a woman scheduled for a treadmill stress test the next morning? Options: A, take your beta blocker medication an hour before arriving. B, wear open-toed shoes. C, avoid eating or drinking for at least 4 hours prior. D, plan to go braless for the test. The answer is letter C. And so when you're the nurse preparing for this client for a treadmill stress test, the most important instruction for you to give to the client is to avoid eating at least 4 hours before the testing. The reason for that, first, is that fasting can reduce the risk of aspiration if there is an emergency, such as a cardiac arrest. And during such situation, the client may not be able to protect their airway. So having an empty stomach will greatly reduce the risk of food or liquids being aspirated into the lungs. The second reason why we need to keep them NPO for at least 4 hours, because the going without food or drink ensures that the blood flow is actually directed to the heart, not to the stomach, which is digesting food. And this is very important because the test's goal is to assess the heart's response to the exercise, and a full stomach could interfere with the heart's ability to react accurately to the physical stress. And this is why you as a nurse should advise the client to remain NPO for at least 4 hours before the testing. Now, why is letter A incorrect? Take your beta blocker medication before arriving. We know that beta blockers can slow down the heart rate. It will reduce the blood pressure, which can directly interfere with the purpose of the treadmill stress test. And so the goal of the test is to observe how the heart responds to the physical exertion, and the beta blockers would blunt that response, potentially giving a false reading of the heart's function. And so clients are typically instructed to hold their beta blocker medication before the test, unless the healthcare provider has specifically instructed otherwise. So it is an important clue that helps eliminate this choice. Now, what about letter B? Wear open-toed shoes. Well, this is not appropriate for this procedure because when the client walks into the treadmill, the client needs sturdy shoes that will provide support and protection from any injuries. And this will lack the stability and protection necessary for safe movement, especially during a physically demanding test like this one. Now, what about letter D? Plan to go braless for the test. This is a bad choice. In fact, wearing a bra is recommended because it will provide comfort and also support during the treadmill test. And it will improve the client's ability to focus on the test without unnecessary distractions. And going braless could make the test more uncomfortable and impractical, especially with the physical exertion involved. And there is no reason to avoid wearing a bra, so this is not the right answer. Remove this right away, okay? So your key strategy in answering this question is to look for preparation steps that directly impact the success and the safety of the test. So anything that could interfere with the accuracy of the test results or increasing the risks, like potential aspirations or, let's say, inadequate support or discomfort, should be eliminated right away. Okay. And when you're in doubt, think about the essential for safety and accuracy. And in this case, fasting for the test is the most crucial step to ensure proper conditions for a reliable assessment. 25. A client's cardiac monitor shows ventricular fibrillation. Which actions should the nurse take? Select all that apply. Options: A, get ready to defibrillate the client. B, bring the crash cart to the bedside. C, initiate cardiopulmonary resuscitation. D, prepare to administer amiodarone IVP. E, prepare to administer adenosine IV push. The answers are letters A, B, C, and D. So let's go into the question. And when you're dealing with a client who has ventricular fibrillation, it's critical to take very swift, coordinated actions to save the client's life. And take note that VFib is a pulseless, it's chaotic rhythm, where the heart actually quivers ineffectively. It fails to pump blood. It will lead to a rapid loss of oxygenation and perfusion. So the body is basically lacking the tissue perfusion. Now, why is letter A one of the correct options here? We know that this is a critical first step, right? Defibrillation. We know that VFib is a life-threatening and defibrillation is the first line treatment. So the primary goal is to reset the heart's electrical activity and also to restore the normal rhythm. And since when the client has VFib, it doesn't generate any effective cardiac output. So the immediate action is to deliver shock to the heart using a defibrillator. And this works to synchronize the heart's electrical impulses and also establish the normal rhythm. Now, what about letter B? Bring the crash cart to the bedside. This is also an important action because the crash cart contains all the necessary equipment and medications needed for the emergency resuscitation. And having it at the bedside also ensures quick availability of the key medications, including the equipment, pads, emergency medications like epinephrine, and also airway management equipment. And in this case, you got to be prepared with everything at hand. It reduces the time spent on searching for the equipment, which can be critical in life-threatening emergencies like this one. Now, what about letter C? Initiate CPR. While defibrillation is being prepared or while it is administered, you as the nurse should also start the CPR if in case the defibrillator is not available yet. And so you're going to deliver the chest compressions and to do the rescue breaths to maintain circulation and oxygenation to the brain and the other vital organs while waiting for the defibrillator. And starting the CPR immediately can also prevent irreversible organ damage, and this increases the likelihood of survival. And again, this is a very critical step to buy time and also provide life-saving support before the defibrillator or the defibrillation can occur. Now, what about letter D? Administer amiodarone IVP. Take note that we have a case of VFib here. If defibrillation does not restore the normal rhythm, then the amiodarone can now be used to help stabilize the heart's electrical activity. And again, amiodarone is a potent antiarrhythmic drug that is used to treat VFib. It works by prolonging the refractory period of the heart's electrical system. It will also prevent further abnormal rhythm. So your role here as the nurse should be ready to administer the amiodarone as well in IV push if the VFib persists after the defibrillation. Now, we have option E as the incorrect answer here. Why is this incorrect? Adenosine IVP. Well, remember what I said earlier about adenosine? This is a drug that is used to treat SVT, supraventricular tachycardia, which is totally a different arrhythmia. And it works by slowing down conduction through the AV node. And this is also effective in stopping the SVT by momentarily blocking the electrical signals in the atria. And the adenosine has no effect on the ventricular fibrillation, which involves chaotic activity of the heart originating from the ventricles, but not the atria. And so giving adenosine in this situation would be ineffective and would just waste valuable time in treating life-threatening rhythm. So what is your strategy to use in this answering this question? Well, you have to focus on prioritizing the interventions that directly address the life-threatening nature of the arrhythmia and eliminate those options that would delay the treatment or ineffective for the specific arrhythmia that is involved in this case. Let's have number 26. A client's heart monitor shows a complete heart block. Which action should the nurse take first? Options: A, notify the healthcare provider. B, prepare for pacemaker insertion. C, obtain a stat ECG. D, administer atropine. Answer here is letter D. Now, when you look at the complete heart block, which is basically third-degree atrioventricular block, this is a situation where the electrical signals from the atria can no longer reach the ventricles. And this disconnect between the two causes the ventricles to rely on a slower backup rhythm, which often results in a very slow heart rate, typically about 20 to 40 beats per minute. And this rate is so insufficient to maintain adequate cardiac output, and it will put the patient at serious risk of complications like syncope, shock, or even cardiac arrest if left untreated. And so the correct answer here is letter D, which is an atropine, an anticholinergic medication that actually blocks the vagal influence on the heart, or it blocks the parasympathetic influence on the heart. And so this medication will increase the heart rate by promoting the natural pacing of the heart through the sinus node and the atrioventricular node. And in this case of complete heart block, where the heart rate is dangerously low due to the disconnection of the electrical signals, the atropine works quickly to raise the heart rate, and it will stabilize the patient. And so this is absolutely the first action to take, as the patient's condition can worsen rapidly without immediate intervention. So what you want to do in this case is to stabilize the heart rate before complications like shock or arrest can happen. So the clue to answer this question is that atropine addresses the immediate need for a higher heart rate. That's why this is a priority. Now, why is letter A incorrect? We know that it's important to notify the healthcare provider, since a pacemaker is often required for a long-term management of a complete heart block. However, this is not the first step. That's why you discard letter A. And in emergencies such as a complete heart block, the priority is stabilizing the patient. And if you spend time notifying the provider first, the patient's condition could worsen in the meantime. And take note that atropine is needed immediately to increase the heart rate and stabilize the patient. And after that, you can notify the provider with the patient in a more stable condition. Now, what about letter B? Prepare for pacemaker insertion. We know that this is certainly a long-term solution for complete heart block, because it can take over the role of a pacer when the AV node fails. However, the pacemaker insertion is a procedure that takes time to prepare for, like getting the consent or setting up the equipment and also coordinating the team. Well, on the other hand, we have atropine, which can be given immediately to stabilize the patient's heart rate. And so while you're preparing for a pacemaker, which is necessary, it should happen after you stabilize the patient with the atropine. So the key here is that pacemaker insertion takes time and cannot address the immediate need for the heart rate stabilization. That's why you're going to get rid of option B. Now, what about letter C? Obtain stat ECG. We know that this can confirm the diagnosis of complete heart block and show the independent P waves and the atria contracting at a different rate from the ventricles. This action is basically redundant in this case, because the heart monitor has already displayed the characteristic signs of the heart block. So there is no need to waste time on an ECG before acting. And your priority here is to treat the bradycardia and stabilize the patient by administering the atropine. The ECG can be done later once the patient is more stable. And so the key here is that you already have enough information from the heart monitors. So obtaining an ECG would only delay intervention. So the most critical strategy here is to focus on stabilization before diagnostics. And so when you encounter a life-threatening situation like complete heart block, always prioritize actions that will immediately stabilize the patient. And in this case, atropine is the fastest and most effective way to increase the heart rate, which directly addresses the client's immediate danger. 27. A client who has ventricular tachycardia is complaining of dizziness. What should the nurse do first? Options: A, administer amiodarone IV push. B, initiate basic cardiopulmonary resuscitation. C, prepare for defibrillation. D, assess the client's apical pulse and blood pressure. Take a look into the case. Client who has VTAC, complaining of dizziness, what you should do first. The answer here is letter D. Why? All right, let's go back into the ventricular tachycardia, which is basically a serious rhythm disturbance originating in the ventricles. And this is something that will vary in its severity from being stable with a pulse and somewhat low blood pressure to being completely unstable, leading to possible cardiac arrest, or let's say pulseless VTAC. Now, when a client with VTAC reports symptoms like dizziness, this reflects signals that the heart may not be pumping effectively. It means there's a decreased blood flow to the brain. And so in this case, your first priority is to assess how bad the situation really is before deciding on a course of action. And the reason the first step is to assess the heart rate and the blood pressure is that ventricular tachycardia can present in a range of many forms. And the patient might have a stable VT with a pulse, but possibly low blood pressure, or they could be in unstable VTAC with a weak pulse and low blood pressure, or maybe worse. So this could be in pulseless VTAC as well, or cardiac arrest. And so understanding the client's hemodynamic status through this assessment is very critical because it helps you to decide the appropriate treatment. And for instance, if the client is unstable in ventricular tachycardia, there's a need for immediate intervention, like synchronized cardioversion or medication. But if they're pulseless, then it's going to be CPR and defibrillation time. And so by assessing the pulse and the blood pressure first, you're avoiding jumping into a treatment that might be wrong for the client's current condition. Now, the key term for letter D here is dizziness, right? Complaining of dizziness, which actually suggests that the heart is not pumping enough blood. However, you cannot decide what to do next without knowing if they still have a pulse and whether their blood pressure is low. And so the assessment will help you clarify whether the patient needs CPR or whether they need defibrillation or maybe medication or cardioversion. Now, what about letter A? Why is letter A incorrect? We know that amiodarone is a medication used to treat VTAC and stabilizing the heart rhythm. However, this step is not the appropriate option around this time. We know that amiodarone should only be given after understanding the patient's hemodynamic status, whether they have a pulse and a blood pressure. And so if the patient is in pulseless VTAC, you cannot give medication first. You must focus on defibrillation. Also, with amiodarone, this is not given until you know the client's status, and giving it prematurely without assessing could be dangerous as well. Now, what about letter B? Initiating CPR, which is a life-saving measure, but this is only appropriate if the client is unresponsive and pulseless. And this client is conscious, right? Because they're complaining. They're actually reporting that they have dizziness, which means they still have a pulse. And starting CPR on a conscious patient would be unnecessary and could be even harmful. And so the assessment of the heart rate and the blood pressure can allow you to confirm if the client is pulseless or if another intervention is applicable. Now, what about letter C? Prepare for defibrillation. We know that this is crucial for pulseless VTAC or ventricular fibrillation, where there is no pulse and the heart needs to be shocked back into the rhythm. But in this particular case, the client is conscious and complaining of dizziness, which suggests there is still a pulse, and defibrillation is for pulseless VT, so VTAC rather. And so preparing for it at this stage would be also premature. And what you need first is to assess whether the pulse is present or not. And if the pulse is there, but the patient is unstable, then you're going to need the synchronized cardioversion or maybe medications like amiodarone. But again, defibrillation would only be considered if they were pulseless. Okay. Now, so your strategy in answering this question is like you have to understand the patient's hemodynamic stability, whether they have a pulse and how strong it is, and this will guide you to the appropriate treatment. 28. A client with sinus bradycardia, syncope, weakness, and a blood pressure of 96/58 is admitted. What collaborative treatment should the nurse expect to be initiated? Options: A, prepare for synchronized cardioversion. B, assess the client's cardiovascular status. C, administer a thrombolytic medication. D, get ready for pacemaker insertion. The answer is letter D, get ready for pacemaker insertion. Now let's go back into the scenario where the key focus is on addressing the client's symptomatic sinus bradycardia. Okay, we have syncope, we have weakness, and low blood pressure, right? And so these manifestations actually point to the heart not pumping effectively, and this can lead to the lack. There is going to be poor perfusion, especially to the brain. And so the correct intervention has to be aimed at fixing the underlying issue of the heart rate being too slow. And that is why we have letter D. And when the sinus bradycardia becomes symptomatic, and if it affects the client's hemodynamic status, a pacemaker is the most appropriate treatment. And it steps in when the heart's natural pacemaker, which is the sinus node, is not functioning well enough. And your role here as the nurse is to prepare the client for this procedure, make sure that you secure the consent, you set up the necessary lines, running the lab tests, and also to collaborate with the cardiologist. Now, why is letter A incorrect? This is synchronized cardioversion. This is not the right choice because this is meant for fast heart rhythms like AFib or ventricular tachycardia, but not slow ones like sinus bradycardia. And since this is a slow rhythm, if you're applying synchronized cardioversion, this would be harmful to the client. What about letter B? Assess the client's cardiovascular status. This is common and also an important nursing action, but the question specifically asks about collaborative treatment. We know that assessment is essential for gathering the necessary data, but it doesn't directly address the treatment the client needs. And collaborative treatment involves working with a healthcare provider to implement the most effective solution, which in this case would be pacemaker insertion. Now, what about letter C? Administer thrombolytic medication. This is also incorrect because thrombolytic drugs are used to break down clots, but it's not used to treat bradycardia, and there is no indication of a clot such as chest pain or signs of myocardial infarction, so thrombolytics are not relevant in this case. So your strategy to answer this question correctly is to focus on collaborative treatment. The phrase itself should help you pinpoint that you're looking for an intervention that requires teamwork, like pacemaker insertion, which directly addresses the heart rate problem. So you can eliminate those other options like B, A, and C. Now, what about 29? While observing a client during a treadmill stress test, which observation should prompt the nurse to act most urgently? Options: A, blood pressure rises from 134/68 to 152/85. B, patient reports feeling worn out. C, heart rate reaches 110 beats per minute with sinus tachycardia. D, T waves flip upside down on the ECG. The correct answer is letter D. Now, you as a nurse observing this client during the treadmill stress test, your main concern is identifying any sign of distress that indicate the heart is not getting enough oxygen. And so this is where the T wave inversion, which is in D, this is critical. And so when the T wave happens, it signals that the heart muscle is experiencing ischemia, Basically, it's not getting the oxygen it needs. And again, this is a red flag because it could be a precursor to a heart attack or more severe coronary artery blockages. And so if this happens, the nurse should stop the test immediately, notify the healthcare provider, and you gotta be prepared for the emergency interventions like administering O2 or maybe administration of nitroglycerin. So this is the most urgent situation in the list because it indicates that the heart is in distress. And if you fail to act promptly, this could result into a life-threatening situation. Now, what about letter B or letter A? Blood pressure rises from 134/68 to 152/85. Well, this is fairly expected during a exercise because the body needs to pump more blood to the muscles and organs. So this increment is expected, especially in the systolic number. So as long as the blood pressure doesn't spike dangerously, we're talking about 200 or more in the systolic, then there is no immediate need for a concern. So this is not urgent. So letter B, patient reports feeling worn out. And so this is another common response during a stress test, and the physical exertion can cause fatigue, which is typical and expected symptom. Well, the key point here is that fatigue alone is not alarming unless it's coupled with more serious symptoms like chest pain or fainting. Therefore, this is a normal response that doesn't require urgent action. So you eliminate this one. Letter C, heart rate reaches 110 beats per minute. And so this is also reflecting a normal physiologic response. And sinus tachycardia simply means the heart rate is beating faster, which is the body's way of meeting the increased demand for the oxygen during exercise. And this is not dangerous for most adults, especially since it's well below the maximum predicted heart rate for this age. And this is also within the expected limits, and it doesn't indicate a problem that needs urgent attention. So your strategy here is to focus on the life-threatening or high-priority findings. And again, in this case, look for the T-wave inversion in D, okay? Again, it suggests that the heart is not getting enough oxygen, and you have to act on this right away. You have to stop the stress testing. 30. A client presents to the emergency department with complaints of chest pain and difficulty breathing. He has acute ST segment elevations in the anterior leads, and the physician orders thrombolytic therapy. Which of the following conditions would absolutely prevent the use of thrombolytics? Options: A, a transient ischemic attack 4 days ago. B, an ischemic stroke 3 years ago. C, 70 years of age. D, blood pressure of 212/114. The answer is letter D. And so you as the nurse, looking at the situation wherein the client has the chest pain, has difficulty breathing, and has a prescription for thrombolytic therapy for an acute ST segment elevation or STEMI. So the most important thing to remember is that thrombolytics work by dissolving blood clots. While this is actually a great intervention to clear the blockages, it also comes with many risks, such as bleeding, which can be a major concern in certain situations. And that is why letter D is the option here. This is a clear contraindication. Your client is in hypertensive crisis. And this actually will increase the client's risk of bleeding, especially in the brain, which can result in intracranial hemorrhage. And again, thrombolytics can exacerbate this risk by thinning the blood further. And with this, the nurse should get the blood pressure under control before considering the thrombolytic therapy, usually through antihypertensive medications like beta blockers or maybe vasodilators. So this option basically is a clear contraindication. Now, what about letter A? Transient ischemic attack 4 days ago. Now, a TIA is a temporary blockage of blood flow to the brain that resolves quickly. While it does increase the risk of having a full-blown stroke, a TIA that occurred 4 days ago is no longer an absolute contraindication or for the thrombolytic therapy. And the risk of bleeding from a TIA decreases over time, and with careful assessment of the client's current condition, the thrombolytic therapy might still be appropriate. So A is incorrect because, again, it doesn't absolutely prevent thrombolytics. Now, what about letter B? Stroke 3 years, ischemic stroke 3 years ago. So this is also not an immediate contraindication to the therapy. While the past stroke may increase the risk of bleeding, but 3 years is a significant amount of time for the brain tissue to heal, which also reduces the risk of another bleed. And the healthcare provider will assess the other factors like the severity of the current heart condition, but this alone does not absolutely prevent the use of the thrombolytics. So this is also incorrect. Now, C, 78 years of age. Age alone does not prevent the use of thrombolytics. While it's true that older adults have a higher risk of complications like bleeding, but age by itself isn't a reason to rule out thrombolytics. And if other treatment options like PCI aren't available, thrombolytics might still be a good choice for the elderly patients, depending on the overall clinical picture. So again, C is incorrect because age doesn't prevent thrombolytic use. So the key strategy to answering this question is to identify the absolute contraindication. Again, pointing to our option, letter D. You can modify this by treating it with antihypertensive. And so, you have completed the 30 items of our Q&A regarding management of the cardiac disturbances. And I hope that you have learned something about the critical situations that we've had dealt with. And I hope that you understood the significance of the use of the ECG, especially interpreting those arrhythmias and also the preparation of this patient that is supposed to undergo the TEE or let's say Lexus scan or Holter monitoring, and also the management of the arrhythmias, ischemia, heart failure, and infective endocarditis. I want you to always prioritize patient safety. Recognize early signs of deterioration that can be life-saving, and also review your diagnostic tests. Also understand the purpose and the findings to help guide your interventions. And most of all, don't forget to think critically. Always consider the most urgent assessment and intervention based on the scenario. So keep practicing, stay confident, and also trust in your knowledge. You got this. And also let us know how you did in this test practice by commenting below. You can also tell us how many points you've gained in this Q&A. Thank you, and I'll see you again in our next session.